And I'm very eager to get back to the question and answer period. Once again, this was just a spectacular set of conversations, a terrific set of comments, Teresa, for your panel. That's, and I think it stimulated a lot of questions on my part, but I don't want to go first. So who else has questions from the committee for this wonderful panel? Jonathan?
Yes, thank you. That was a terrific set of presentations. I liked, Bobby, your sort of delineation of the different measures, and I mean, you all had sort of a nice way to conceptualize sort of how to do the measures. And one of the measures, some of the measures were sort of things like the acute services, like treatment for drug addiction. And I'm thinking about practically how to actually measure this, because there's always this question of like, well, is it good that it goes up, or is it good that it goes down? Right? Because there's an underlying prevalence of disease. You want that to go down. You want people to be treated. So how do you actually deal with that practically? Do you try to get estimates or imputations of what the sort of the disease burden is and then ask what fraction are being treated, or do you just kind of report the number and let people kind of make of it what they want to, or what?
Yeah, I mean, that's a problem. That phenomenon is true of all things under surveillance, right? I mean, diagnosed diabetes is the same thing. Do you find undiagnosed cases and the number goes up, but it's really a good thing because now there's a chance for engagement and so forth. So one thing that is important is to see these things longitudinally over time. So you're not looking at a sort of a number in the abstract. You're looking to see to what extent has the trajectory within a population been going in a particular direction, and with some explanatory framework around why. If it's because of greater availability of services that let's say are more reimbursable now, or there's more outreach or more understanding, then you may see more people in treatment and take it as a good signal of a problem that was otherwise prone to create more adversity and more harm than otherwise would have been the case. At the same time, the very state of needing drug treatment is a sign of a deeper structural problem of risk and vulnerability, and so the interpretation of that measure is both a call to help the people who need help and should be taken with a kind of a bifocal view of saying there is something more that we need to do to safeguard various vital conditions, and there's a one-to-many relationship to those urgent services. Very often a mosaic of shortcomings would become conspicuous on the vital condition side, and then you can begin to make progress there. The good news is it goes the other way, right? The minute you start to assure, let's say, a housing first sort of intervention, you can see an array of benefits that show up in various categories of vital condition urgent services. So they're very intertwined, and the likelihood of sort of developing one as a result of any other is very high. So they're tangled in that way.
Right. I understand the tangledness, but I'm still confused as to it seems as if what you want to measure is access, that if you have a cleaner measure of access, especially for change, this is exactly what I have in mind is longitudinal changes, that would be where you can look at it and decide it's going up or it's going down, and that's a good or bad thing. This is why I like measures of health and health outcomes like mortality. There's no question that when mortality drops, that's a good thing. But if the only way you can interpret this measure is by reference to other measures, then I'm sort of confused as to how,
I wouldn't say it's the only way. I mean, the premise is that the state of addiction is a by definition a harmful thing, and so there's a straightforward interpretation immediately when the demand for there's a supply and demand dynamic going on here, and to some degree measuring access without measuring demand is missing a big part of the story.
Exactly.
Right. So the key issue is what fraction of the population is experiencing this adversity. Now, there's more nuanced interpretations around it that say, to what extent are we as a society meeting that demand? How many people get the help they need? How many are left out of it? So you can think of, the fraction of homeless that are that are sheltered and the fraction that are not. So these are all population fractions, and the question is who's in and who's out of what state. So they're different states of being. It's just more in the service and policy realm than it is the states that individuals could report. That's the key difference.
So I've got a number, terrific. If you could put your cards up, I've got two from on the web that I'm going to go first to. One from both Ebony and one from Darcy. So first from Ebony. Excellent panel, she comments. The speakers have emphasized that measuring well-being requires an integrated lens, including new and existing measures of a number of indicators that jointly contribute to health and well-being. First of three questions. What are the biggest gaps they see in addressing health and well-being at a national level? To what extent are some of the repositories held in specific states or smaller municipalities as opposed to national federal, that sort of local federal thing with respect to data? And then how much focus should there be on local community level measures versus more broad or regional or national metrics?
Hi, or whoever's on the line. So a couple things. On the first item, one of the things that can probably be relatively easily done in national surveys is to try and embed a more consistent set of items that relate to subjective well-being, which would get at some of the concepts that myself and the panelists and others have been pursuing, which would capture things like resilience, life appraisal, thriving and flourishing. That would capture at least a little bit more than we have consistently. Some surveys are starting to introduce that, but that's certainly not as common or typical. In terms of both national and community level surveys, the ability to capture detail on some of the amenities that are available to promote well-being are not always as consistently tracked. So, for example, in the Culture of Health framework, we capture national data on the availability of public libraries and other things that we know are indicators around equity, but also promote access to health promoting, well-being promoting amenities. These are the kinds of measures that aren't available consistently in national data sets you can get from national organizations, which is why we've been able to include that example. But we don't have many indicators of social environment, a kind of economic environment beyond the things that we capture in BLS or in the American Community Survey. So I think that's why so much of this has been locally driven, because there's a little bit more of an opportunity to capture some of the things that we know in the built social and natural environment that actually promote well-being.
Yeah, I'll just add one other thought. In complete agreement with what Anita just spoke to, but also speaking to the value of local communities, municipalities, having access to a library of measures that they will be able to leverage in their own improvement work locally. So in working with many different communities, they're hungry to know what's the best way to measure this and how are others measuring this so that we can all learn together. And so there's additional value in providing signaling with measures in that local uptake can be very meaningful when it's guided, and then can create opportunities for shared learning, particularly where there are bright spots in which great things are happening and other communities want to know about it.
Terrific. Let me have another question. And first, I want to note that Soma Stout is here. Thank you so much for being with us and for prevailing against the travails of travel.
Of course.
I think what I'll do is I'll give you a chance to make some comments, but not right away. I want to be right in the flow of these questions. So if you'll bear with me a bit. So I will come back to you, okay? But I have a question specifically for you, Carly. From Darcy, Phelan Emmerich. Regarding Cantrell's ladder, how has this measure been used in the past by governments in the U.S.? Is it used in any country at the federal, state, and local levels? In her opinion, it would be helpful to have such a measure in BRFSS or the U.S. Decennial Census or the American Community Survey. Thank you for a fantastic presentation by all the panelists, she says. So if you could respond to Darcy's question.
Excellent. Thank you, Darcy, for asking that question. So Cantrell's ladder has been utilized as a national measure in multiple other nations. It's also been used globally to compare thriving across nations by international stakeholders as well. Here within the United States, well-being by use of Cantrell's ladder has also been tracked since 2008 by the Gallup group as well, and those data are published with frequency and are increasingly available. We have data from Gallup for well-being using Cantrell's ladder at the national, state, MSA, and we also have access now to county level data as well. It is it has been being used. However, I would second and third Darcy's call to having Cantrell's ladder be woven into other data systems like BRFSS or ACS or through the census perhaps, because it is such an extraordinarily important and valuable measure.
Terrific.
Shona has, I'm sure, something to add.
Well, there are state and local governments that have been using Cantrell's ladder already to guide their progress. A number of counties and municipalities have added it to their community health needs assessments as well as to annual improvement measures. The state of Delaware tried to actually get it into their state BRFSS, but when they weren't able to, added it to both their consumer surveys as well as their statewide dashboard in terms of measuring the progress of improvement of well-being as they address mental health and addictions in a comprehensive way. Massachusetts has asked for it to be added to their dashboard. So there are a number of states that, as they've been in the testing period around this, and communities that have begun to integrate this into their existing measurement systems, and they all echo that request for it to be added as part of our national measurement system.
And I know IHI does a fair amount of work internationally, and Darcy's question asks, is it used in any country at their equivalent of federal, state, and local level? And any comment you may wish to make on that, or any panel member
Sure.
might want to make on the international use would be helpful.
Some of you may have heard of the World Happiness Report. It's used in Bhutan as a way of guiding their development. New Zealand is just said that they're going to be doing their budgets based on well-being, and all of these groups are looking to the Cantrell's ladder questions as part of the World Happiness Report, which embeds them. The OECD has recommended these two questions as part of how all OECD countries assess the population health and well-being, and use it as a measure for progress. So I think we would be in very good company with other countries around the world who have been really thinking about how to organize their business less on a reactive agenda and more, or simply on a financial agenda, and more on a how do we improve the well-being of our citizens agenda.
Other comments, Teresa?
So I'll just say that the Healthy People Advisory Committee really talked a lot about having some measures that would increase our ability to compare ourselves to other OECD nations. So if indeed something like this is embedded with other OECD nations, it's I'll speak for myself and not the committee, it seems like a no-brainer as a way to sort of move forward to be consistent with how we framed Healthy People 2030.
Very good.
I think one sentence that I agree with the virtues of that as a measure and its comparability. That is also a marker of the extent to which globally there is a discernible shift to focus on sort of health and well-being in a broader sense, restructure economies to move beyond GDP. This is an area. Happiness and well-being is a serious area of economics. There have been a string of Nobel Prize winners in economics in the last decade that have talked about how do we organize resources very differently and governance to to actually produce lives that people value. And a lot of that movement, by global comparison, the U.S. is decades behind many other countries in that shift. So this would be a great step forward in bringing us into conversation globally on these same questions.
The only thing I would just add is I think it's absolutely right that there's been much movement from those other countries and what Tim and team are doing in New Zealand with the economic models. But as you think about kind of implementation and structure, I would also commend the group to think about how far they haven't moved. I was just in a meeting in Canada, and this has been a 2-decade-long effort to try and have these measures move local and federal policy. So it's not that we shouldn't push on that, but I think there's a lot of insights and lessons from those other countries about where they are now and truly actually moving the needle with the insight they have on well-being to actually tying it to policy and budget and other things. It's not so easy. So definitely in support of the conversation, but there are some great insights from our non-US colleagues that I would also bring along on the implementation side.
Yeah, that's a terrific comment. I'm going to go to Sherry, then Gil, Paula, and then Martha. And then I have questions.
So mine is also about the subjective well-being. So I'm trying to put together some thoughts. They may not make sense. But if there are populations who generally report higher levels of subjective well-being, I'm thinking of like African American adolescents who usually have higher levels of hope and et cetera. If we start to measure that and show that those historically marginalized groups still maintain a level of thriving and hope, does that actually give rise to permission to maintain conditions that are unequal? So what are the trade-offs in terms of knowing that there are groups that make a way out of no way and yet live in conditions that are inhumane?
This is a question I hear a lot, so thank you for raising it. I think it's absolutely critical, and this is why I'm a big fan of measuring conditions of the environment, of policies, of governance and structures, and not simply measuring subjective well-being. And some of our colleagues who aren't here today, Carol Graham being one of them, is actually looking at this issue right now in terms of aspects of hope and resilience as protective, and yet those conditions actually haven't evolved. So as much as we're looking at life expectancy declining in middle-aged white Americans, conditions are still not better for people of color in the U.S. And so if we only measure Cantrell, we will miss it. And so the extent to which the objective around social determinants of health is actually capturing systemic and structural determinants of health and not simply social clinical factors that filter to health, that's going to be as critical, if not more so. It's absolutely great that we should capture subjective well-being, but it's an important caution.
Yeah, I couldn't agree more. In fact, that's why the well-being in the nation measures don't just say, let's just measure subjective well-being and think we're done. In fact, it suggests a portfolio of measures at multiple levels that keep going deeper and deeper into those causes. And even for the well-being of people, says what's subjective well-being, but also adds life expectancy to that as a measure that sort of holds the frame of what needs to still happen in addition to actually picks up really important trends of resilience. I have to say, as someone who 100 Million Lives says equity is the price of admission, so we look at everything from a lens of how will this impact equity and our piece. What I've come around to is both the ability to see real differences in resilience and actually be able to have a conversation about that matters. Beginning to change the narrative that actually the myth of the angry black man or woman is absolutely debunked as a myth. In fact, if you really want to improve the well-being of your community quickly, actually getting people to actually desegregate and having people of color move in can actually be a coherent way. There's different narratives that we can begin to tell, but also narratives around what we're seeing is happening in rural communities that are actually changing health outcomes and behaviors, or whether it's around voting or around health behaviors that just begin to be important to understand. But for us, not only the balance of life expectancy, but those underlying policies and the leading indicators that underlie the WIN framework that are in each of those domains that say who has $400 to spare for an emergency expense or other measures like that, I think are crucial to look at in addition.
Mm-hmm. Yeah, I will, if I may, I would like to second that in terms of the bringing together subjective well-being as an outcome along with life expectancy as an objective measure, a health outcome. And in fact, not only is that built into the WIN network, there's a broad academic discussion as well on the great value of that as well. So we would stand on good ground from that standpoint as well. And then just to push a little further on seeing hopefulness that seems to be out of proportion potentially to context. In the communities in which I am engaged, in which that is the case, that is seen as a great asset and something to then not just be not measured and discounted, really, but to actually be lifted up and then leveraged towards other gains as well for those communities. And so I think it is a part of that narrative. And what is it that we do with that finding and having the complement of measures around it to help tell that narrative that moves us towards equity and action as opposed to moves us away from that.
Yeah, I'll just say for one sentence, and that's exactly the reason why we frame the vital conditions as normative expectations, not discretionary things, so that they're not just instrumentally helpful in alleviating adversity, they're part of the definition of what produces health and well-being for everyone.
I want to thank you all for a great panel of presentations. I enjoyed it immensely. So my question is really thinking about all of your presentations as a whole. You know, there are all these big picture concepts of structural discrimination, life course, well-being of places, governance, and all that kind of stuff. And it strikes me that a lot of these concepts, which are very much consonant with this idea of social determinants, can be thought of either as some things could be measured as aggregations of individuals, but many things cannot, that require sort of linkages across data sets that may not necessarily be national or have the time scale that's been put forth in some of the documents that are out there. I'm just wondering if you had any thoughts about that kind of difficulty.
The purpose of WIN was actually to address that and to bring together a collaborative across organizations, federal and non-federal, that could help to actually address the lack of connection across our multi-sector data sets. So the Wellbeing in the Nation website that will soon have these measures in one place, and that where the measure descriptions actually say, here's this ties to this other measure and this other, and you may not be aware of this measure, but this information exists about housing, even as you're working and thinking about asthma and housing, whatever the pieces are. How do we actually first take the wealth of data that's already out there and bring it together in a meaningful way? I think the Vital Conditions do a wonderful job of exactly the same thing. And I think one thing we've agreed is across our two initiatives, let's align measures so we're not, however we help people see the connections, let's help people move people toward a common set of measures that people can begin to play with and learn from. I think there's so much to be done to go beyond measure selection into a process of learning as a country. And that's really the invitation that I know we're deeply committed to, that a number of partners have come together around. In reality, whatever we've chosen now is our best guess now about what will improve the well-being of the country. And its health. We have we've done that based on experience, we've done that based on evidence, but in reality, what we need to do is engage in a learning journey that helps us understand, for instance, whether non-traditional things like perception of everyday racism ought to be something we all look at because it turns out to be so important and modifiable. And until we get past the which measures will we choose into a shared learning journey together, we can't get there. And I think that's the real opportunity we have.
So we're getting close to our time, but I want to get all these questions, and I'm going to cut into lunch. But Anita, I want you to make your comment, but I want all of us to be mindful that we need to be to the point.
Yeah, just, the one thing to think about is how the measurements fit in a philosophy or a framework. I mean, what are you intending the measures to do or catalyze in terms of the kind of narrative and the shift in narrative? And so placing data sets together can do that if it tells a deeper or more qualitatively impactful story around equity. We just ran another national survey of health attitudes in the U.S. Still, less than a third of Americans understand that their surroundings influence their health. So anything that can be done in the measure set that tells that narrative is also as impactful as actually monitoring progress. But it's really up to where you're situating this measure set relative to everything else.
Paula.
I want to echo my thanks to all your great work and being with us here today. So Bobby has said a number of times, the word normative, that these vital conditions are normative expectations, and I'm sure we all agree with that. And I would like to think that our society at its core shares the values in these models, but it's not the case. I mean, I'm going to get real here, not in a political way, but people, elected officials, people who allocate resources, and other policymakers clearly by their actions don't share some of the fundamental values in here. Mindful of time, George, but three quick examples. We all know poverty is bad for children, and what have been the poverty rates for children in this country across decades, across administrations, and varies greatly by race. Residential segregation rates are going way up in this country. Voter suppression efforts, from gerrymandering to more overt ways of decreasing voter participation rather than increasing it. We all know that these things are going on. So I'm just calling out the reality of this enterprise here and wondering if you can share with us, how do you deal with that reality that this is in fact a normative process? How can selecting leading health indicators, move values in society? I'm not sure it can. And I say this, I'll admit it. So I've been in the world of population health and public policy for over 30 years, and I'm tired of saying poverty is bad for children. We all know that. So maybe I just need a pep talk. Thank you.
There are two pieces to differentiate there. One is the pragmatic realities of what actually produces health and well-being. Even if a society disagrees about it or can't get it done, that doesn't change the fact that it's necessary. So being clear and being sort of in relationship to the accumulated wisdom and science about what actually produces health and well-being and what moves us away from it, that seems to be job one. Job two is to be able to have an open and conspicuous discussion about, are we moving toward or away from those conditions? And the who's the we in that is going to be forever contested. It's going to be politically challenged, and that is part of the nature of this work. We, for a long time, have treated public health and healthcare as a sort of technocratic science, when really it is also a political science. And by that I mean political in the ordinary sense of the word, not the partisan sense of it. It can become partisan, and that we should examine, the extent to which there is a contest of ideas of what it takes. But in terms of lifting up, what are sort of a core set of things that human beings and human populations need to be healthy and well, that I think you're on pretty solid ground to come up with a pretty short list. It doesn't have to be my list. It can be a list. And if we can't do that much, then I'm not sure what the eroded goals we are then moving toward would accomplish.
Okay. Teresa?
Can I add just one comment? So given your comments and given his responses, and I think given what we think, one could argue that the leading health indicators, when we think about the balance between health states and the upstream determinants, should really weigh heavily in the upstream determinants and the structural issues that drive health. If we really believe that, whether you're optimistic or not, it's a way to have that constantly in the nation's face. So that may argue in terms of how you think about the balance of LHIs.
And Shoma?
Sarah Smarsh was talking, she's the author of Heartland, and talked about how it's so easy to take a 1% difference in different states and draw a map that's red or blue, when in fact we probably live in a country that's much more purple than we give it credit for. And in reality, it's in our public discourse that we shape the norms of our communities. And that's our discourse between neighbors, and it's the discourse that we have in the media, and it's the discourse that we have when we pick up the kids after school. And I say that because over the last, I think measures are just one part of a solution. If they're not accompanied by storytelling, and if they're not accompanied with capacity building and actual paths forward that people can take for how to shift, they don't change anything. This will be like any other effort. But I think part of what we've proposed that these sets of measures be part of a national ecosystem to shape and change narrative, but also help people take action. And over the last 4 years in 100 Million Lives, we've watched states of South Carolina choose to take on racial equity as a priority and talk about the racial segregation, but also their inherited racism, and come to deal with that and begin to think about that at the legislative level and at the local level. We've watched the state of Wyoming go from not in my backyard responses to how about in my spare room responses, as they came to realize that homeless runaway youth were their future community leaders, not those youth to be shunned over there. And I think that there's something around us understanding where measures fit as a catalyst as part of a larger ecosystem that I think we have an opportunity to grow into.
So, mindful of the fact we're cutting into lunch, go ahead, Martha.
Okay. So again, thank you all very much. We are, given the opportunity to give advice about perhaps other objectives that could be added to sort of round out the leading health indicators. You may recall that there are core objectives, there are developmental objectives, there are research objectives. We're supposed to be talking about the core objectives. There is some sense that we need to work from an evidence base when that's a reliable one, when we're proposing the core objectives to be added from which LHIs can be selected. I'm thinking that there's going to be a discussion, perhaps later this afternoon, about what constitutes an adequate evidence base, and I wonder what comments the panelists might have in sort of shining light about what we can propose as being adequate as an evidence base.
I have one quick reaction to that. First, from a design perspective, you want to work from the end use case backward rather than sort of be devoted to a list of measures and pick the best you've got, knowing that there may be real baked-in flaws that just don't get the end result that you want. The most wasteful and confusing thing that could ever happen to the country is to come up with a set of indicators that as designers is sort of flawed in some very fundamental way, just because you were pulling from some pool and not another. So the question is, what gets into that pool? Not all things need a randomized trial to prove that it's important, right? Human beings need clean air, clean water, nutritious food. There's only so long you can go without that. And you don't need a randomized trial to prove that sort of evidence. There's also a kind of evidence that has grown up in our field that is very transactional. It's designed by the nature of the intervention research to filter out a lot of other context, to not count a lot of other co-benefits, and zero in on those things that are most attributable. But that then often skews the evidence base to the most narrow and focused interventions, not the ones that have the most systemic effects. So I would be a little bit careful with understanding the bias that led to the evidence base that is classically in, sort of narrowly parsed research articles, and more the evidence base of what we've seen over generations on how these systems behave and what the summary measures of performance end up being until they change in some fundamental way.
The National Committee on Vital and Health Statistics, and then everybody in the stewardship, the metrics stewardship group and development group for the WIN process gave us very clear direction that if we just use the measurement system we have, then we'll reproducibly get the same result. And there's a wealth of evidence that that measurement system doesn't work. And therefore, they highly recommended that we choose a balance of measures that are some of the existing tried and true ones that we all know and love, like life expectancy, but combine that with developmental measures that have strong evidence of validity, reliability, and objectivity, but we may not have played with as well, or other sectors might have played with, but perhaps in the health sector we haven't applied. And that's really part of what led to the recommendation, for instance, of Cantrell's ladder without us voting on that measure ourselves, because there was plenty of evidence of its use in other sectors. And while I'm talking about that because we've happened to talk about it, there are a number of other measures like that I think if we push ourselves, that get us farther upstream and to those system factors that would help us have a hope of getting to a better outcome than we currently are at. And I think that's the challenge we have the opportunity to wrestle with, that you, as HB 2030, have the chance to sort of carve a new path toward. And I think it would be interesting to explore how to align at all three of those levels between Healthy People 2030 and WIN, between the core objectives, the developmental measures, and the research agenda.
You just might want to, one thing you might want to consider the extent to which, and historically, I don't think Healthy People has done this, you have national measures of policies and structures and not simply process and outcomes at the aggregated individual level. So for example, in the Culture of Health set of illustrative measures, we measure the percentage of families that have access to FMLA policies and actually can afford it. These are the kinds of upstream drivers that have cascading impacts on everything from aging populations to caregiving to chronic disease burden, so that you have a leading catalytic indicator that has all these secondary and tertiary linkages, and you can do the stem and lead, whatever diagram, and link them up and tell a story. Why do we have access to public libraries? Not because we think public libraries is the be-all and end-all, although we got a lot of joy from librarians around the country, but because it's an indicator of investment in community amenities. And when that doesn't happen, other things don't happen either. So I would really encourage kind of a different measurement philosophy to the extent that that's open. The other thing I just wanted to say about the earlier comment is reimagine Maslow's hierarchy and maybe take it off the table in terms of how you're thinking about everything. And that goes along with, I think...
That sounds great.
Yes. Because I think that is where the world is moving, that's where the field is moving. That'll take the shackles off, if you will, of an orientation to measurement that's not going to work going forward. Just a thought.
Thank you.
So I have three questions before we move on. And I know we're really time bound, but Therese, we want to make a brief comment? So specifically for Bobby, I'm going to be focused too, if I'm going to try to be. In your portfolio element wheel, you have urgent and then vital, but I don't see health literacy in the urgent part.
Oh, sorry. Health literacy would be among those things that are part of basic needs and sort of probably arguable part of lifelong learning as well. So it's among the vital conditions.
That's what I mentioned to Alina, and she pointed out the same answer. But I'm aware that some interventions in dealing with health literacy are short-term and remedial, as well as longer-term, and might be considered urgent. But
yeah, well, so we could get into semantics about that, but yes.
The second comment is, given your very insightful set of slides about the process of how people learn over the lifetime and then how systems learn over generations, I don't have the slide in front of me, so I don't know if I'm paraphrasing correctly, but thinking about that with respect to your portfolio, is there enough in that whole portfolio to really think about the underlying drivers in the long run of promoting health in the nation? I'm thinking about education levels, income levels, and those kind of things, which I think there are some elements here, but I'm not so sure. It seems to me that Healthy People is, given the intergenerational sort of history of it, needs to have a component that might be short or long term, given your remarks. That's not an opinion of the committee or my opinion necessarily, sure, but just for the sake of this discussion. And I'm wondering whether or not there are enough of that kind of intergenerational, long-term, leading health indicator. Are we making the investments today that we need to be making so that we get that longer-term dividend, as opposed to what we need to,
It's a great question. I would refer the committee to a group of primers that were written by the Wellbeing Legacy Project last year. 2 pages for each of the 7 vital conditions, so 14 pages that try to describe some of the reasons why these conditions matter, but also the history, like broadly told over generations that bring us to the present, and then the prospective considerations, some of which are working in our favor, others of which are really presenting some major challenges going forward. So that document summarizes a lot of the long-term structural dynamics at work. And I guess I'll say the structure itself is flexible. It's a question of what we bring to it. Are we going to look at the deep history behind some of the contemporary conditions, or are we going to look in a sort of a narrow, recent frame around those things? But but it does matter, and it's situational.
My last question for the panel looks at the issue of geography. I'm aware that, at least in many public health publications, there are marked usually by urban area maps, usually along metro lines, of the variation in life expectancy. And then some of my informal analysis I've done in the state of California with respect to something as well established as colon cancer screening. A disparity that aligns with geography of income, education, and advantage in insured populations. It's quite marked in the state of California. But then also marked with respect to insured compared to Medicaid populations, and then less marked with respect to racial disparity among Medicaid populations. And so there's a hierarchy, if you will, of factors that really is emphasized in a way I've not seen it emphasized when you begin to look at the geography of some of what we've done. So again, thinking about healthy people, I know the Healthy People 2010 process has interim reports which display many of the indicators by race and ethnicity. But I'm wondering if there isn't an opportunity for us to learn a lot more about looking at some of these proxies for some of the underlying factors, and then digging into some of the rationale for how we might address the equity sorts of issues by doing that sort of analysis. Any commentary you'd like to make in terms of the opportunity for looking at geography and geography disparities?
We organize the Well-Being of the Nation framework around the well-being of people, the well-being of places, and equity, so that we could help people begin to see the interconnection between them, and help traditional sectors who are often very people-focused begin to realize that if they didn't address some of those underlying geographic variations, they wouldn't get there. But as you spoke, George, I have to say where it took me back to was a practitioner in the safety net in many such places, where the reality is what we ought to measure, even if we were just trying to close gaps in healthcare services, is the percent of clinicians accepting Medicaid, because that's actually the new redlining that is our current state within healthcare, because not accepting Medicaid, because it offers lower rates, is the easiest way to continue prevailing disparities. The number of clinicians in those areas is lower. These are all often medically underserved areas or health provider shortage areas. But the same is true for any other sector. While that's the lens that we might look at it, it's the same areas that are the food deserts, the same areas where ACEs are high. They're the same areas where if you take a look over time, you see maps of economic hardship, childhood obesity, to 20 years later, diabetes, 20 years later, poor health outcomes and cost. And I think until we can begin to surface and help people understand the legacy of structural racism that is part of our history, that shaped the policies that are there, and begin to help people understand how we can actually change those policies, because it's overwhelming if there isn't some pathways to take action. I think my guess is we'll be here 10 years from now having the same conversation. And I guess our question is, how can we not take this opportunity to help those come to the surface?
To add to those comments, we've also selected to have differences in certain measures be measures in and of themselves. And so it's not just that we're looking at life expectancy and then, oh, by the way, we are also looking at how that measure performs across different sociodemographic groups. We're highlighting that, in fact, looking at difference in years of potential life lost or differences in life expectancy is a measure in and of itself that should be valued as a part of the parsimonious core set that we do a lot of sense making around to drive action to improve equity and eliminate disparities.
I don't disagree with anything that's been said. I just would urge everybody to think differently about equity than we do think about difference, because your access to opportunities is rooted in a history. And so what kinds of measures are going to capture the system structures and histories? That's why thinking about available policies and those kinds of structural factors are absolutely essential. And so I think there is a time to look at differences, but I wouldn't enter into the conversation about gap closing or differences, or we'll end up in a health disparities conversation that we've had for several decades. And so one exercise that I might suggest, you've got the bigger task, is to do exactly what was suggested earlier, is to take a look at all the measures against what we know actually influences and produces health. Then look at it through an upstream driver's lens of what is actually access to opportunity to produce health. Then later look at the subdivisions that you can do by geography, race, income, and all of that, as opposed to the usual way that we approach measure selection and development. It's just a thought. It will perhaps lead to a different set of outcomes conceptually.
I could not agree with that more. That's an incredibly wise position that should absolutely be highly commended.
You have the last word before we go to
Oh,
lunch.
isn't that wonderful?
Or before we move on
I
to the
actually
next
think
one.
you're right on target with geography. Healthy People right now has urban versus rural. Those are sort of gross differences. So geography matters. So I think if we think about thinking about risk to health and well-being over time and space in terms of the intergenerational, so think about the Hulk maps from the 30s and redlining. We have papers that show directly that's related to where fire and violence happens in Philadelphia. It's exactly in the redlining. So intergenerational time, and think about time and policy, and think about changes over space. And the final point I'll make is if you look at the law and policy brief that came out of the advisory committee, we absolutely believe that is the biggest lever to improve health and well-being, and really is something to be considered as you think about leading health indicators.
This is terrific. Actually, I'm not so sure I would personally agree with all of that. I would agree with the points made about the importance of these levers. But my work with the community guide now almost 2 decades ago led me to the conclusion that many of the interventions that were manifest at a population level were multi-component. And for me, it's almost a both and from that experience, as opposed to let's pick the most important one and only do that one. And I know you're not saying that, but just to add my own personal comment to that. So we're going to move to the next panel. I would love to continue this conversation for the rest of the day, but we won't. So thank you very much.